company and will ask the first question. On questions, we have, as everyone who is an old hand here knows, the opportunity of both written and spoken questions. For those of you brave enough to stand up, there will be a microphone in the center of the room, and we will give priority to oral questions. I have the opportunity of editing the written questions, so if you want an unedited question, you may want to stand up and ask it yourself at the microphone. I will remind everyone that questions are the privilege of City Club members only. I would also remind everyone that a question ends in a question mark. The stories now seem to appear in the news daily. Stories about child abuse, physical, sexual, and emotional. Stories about neglect and about drug-addicted babies. This is the second in a series of children at risk programs that the City Club is putting on, and we're very honored to have a very special speaker with us to share her views today. I'm going to take the opportunity to read from a program that was part of a program that she won an award from the Department of Health and Human Services, the Commissioner Award. And I read this because I think it best articulates Dr. Jan Bays' background and why we asked her to be here today to speak. Dr. Bays has dedicated her medical career to reducing the re-victimization of the child who has been abused and to breaking the intergenerational cycle of abuse. In recent years, she's demonstrated leadership and vision, working with the community to create the Child Abuse Response and Evaluation Services, CARES, the first regional assessment center in Oregon for children who have been abused and neglected. Dr. Bays provided numerous educational seminars on child abuse to physicians, social workers, judges, and law enforcement personnel throughout the state, and I might add throughout the nation. In addition, Dr. Bays continues to devote her medical practice to caring for child victims of abuse and neglect. Speaking on abused kids, reducing the risk, will you help me welcome Dr. Jan Bays.
Thank you. Thank you for that nice introduction. I come to you from the CARES program, which is the Child Abuse Response and Evaluation Services program at Emanuel Hospital. We have evaluated over 1,000 children in the last 2 years. These children come to us when there's a high suspicion of abuse or neglect, and we do a medical examination and document any findings relevant to abuse with photographs, and we do a videotaped interview so that the interview is carefully documented through the videotape. This program has been generously supported throughout the state, both by the Fred Meyer Charitable Trust, by Multnomah County, by the Sunshine Division, and by Emanuel Hospital. People often ask me, if they don't know who I am, what do I do if I'm at a party or a gathering? And I usually say I work at a hospital. And then they say, well, what do you do at the hospital? And I say, well, I work in a clinic. And then they say, well, what do you do in the clinic? And I say, well, I worked with abused children. And then they say, oh, and they change the subject. Sometimes they say, how depressing. And in a way it is depressing, but it's also very encouraging to work with abused children. I want to talk a little bit about the depressing aspects and also about the encouraging aspects. Yes, it is depressing to work with abused children. More children die in the United States from child abuse than die from leukemia. We think there are about 5,000 to 6,000 deaths per year in the United States from child abuse. Homicide is now the leading cause of child death in many cities in the United States. Homicide due usually to gunshot wounds. And even in children under a year, if you discount sudden infant death and congenital anomalies, child homicide is the leading cause of death in Oregon for children under 1 year of age. The number of validated cases of child abuse in Oregon has risen phenomenally. In 1978, the total number of validated cases was 1,598. Of those, a third were child sexual abuse cases, 529. Now, 10 years later, there's a tenfold increase, 15,000 total validated cases of child abuse in Oregon, of which about 3,000 were child sexual abuse cases. It's depressing to find out that 1 in 5 girls will be molested before the age of 18. And the statistics say that 1 in 10 boys will be molested before the age of 18. But if sexual offenders in prison are interviewed about their victims, they say that more than half of their child victims were boys. So it's kind of depressing to find out that the boys are somewhere out there and we don't know where they are. Why are they not coming forward and letting us know that they are victims? Partly because they're ashamed because of our culture's mores about boys who are victims, and partly they may be ashamed because their response to, say, sexual abuse may be one of arousal, and that makes them doubly ashamed that they're a participant in the abuse. It's depressing to hear day after day child victims talk to us about the amazing things that people can think of to do to children, to harm children. Each time we think we've heard it all, then a child comes along and tells us something new. And I will not go into details on about what children say to us at a lunchtime meeting. So it's depressing in many aspects, but it's also very encouraging to do child abuse work. First of all, it's encouraging that we as a society recognize child maltreatment and call it child maltreatment or child abuse or neglect. Child abuse has always existed. People ask me this question commonly. Has child abuse always existed, or is it a new phenomenon? Child abuse has always existed, but it was not called child abuse in times past. For example, Romans commonly abandoned unwanted infants on the hillside to die. And it wasn't just the Romans, that's also a modern practice in some countries, that unwanted, particularly girl infants, are abandoned. I lived in Korea when I was a child, and at that time I worked in an orphanage, and very commonly girl infants were brought in from garbage dumps where they had been left because girl infants were unwanted at that time. Greeks used young men and women, young children, as prostitutes. But again, that's not an ancient phenomenon. In Thailand, now there's a thriving industry in child prostitution for businessmen who visit from other countries to Thailand. In fact, the AIDS rate in the child prostitutes in Bangkok is quite high. And in Portland, we also have mothers who sell their children into prostitution for drugs or for money. In the 17th century, to give a little more of a historical perspective, in the states of Massachusetts and Connecticut, there was by law a death penalty for children whose fathers deemed them unruly. So a father was able to have an unruly child put to death legally in the 17th century in the United States. And when neighbors of a child who was being beaten on a daily basis and chained to her bed all day long attempted to report this to the authorities, in the late 1800s, they had to use the Society for the Prevention of Cruelty to Animals because there was no agency for reporting cruelty to children. So we established agencies for reporting cruelty to animals in this country before we were concerned about cruelty to children and how to prevent that. Child labor laws, of course, are very new. If you read Dickens, you know that children up until, 50 to 70 years ago could work 7 days a week, 6 days a week in factories, sometimes chained to their machines. So recognition of what we call child abuse is actually a recent phenomenon. In the 1940s, Dr. Caffey published a landmark article on children who had multiple fractures and also bleeding in their brain, subdural hematomas. He knew that this was caused by parental abuse, but society was not ready to hear that, and he was not allowed to publish that in his article. In fact, the blame was put on the children, and they invented a new disease called osteogenesis imperfecta tarda, which means the bones don't form correctly and therefore they break easily. And that we know that that can occur, that is a genuine disease, but it occurs in infancy and it's diagnosable in infancy. But they made up a new disease in saying that this happened later in life, that suddenly your bones became very brittle and they just broke of their own accord. So we tried to blame the child for the child abuse that was going on. It wasn't until the 1960s that we really recognized that child physical abuse was a common phenomenon. And Dr. Kemp from the Kemp Center in Colorado began to write on this, and the first child abuse reporting statutes were enacted. That's about 20 to 25 years ago that we first began to be required to report child abuse. Dr. Kemp estimated that there would be about 450 cases of child abuse reported per year in the United States. There are over 15,000 in Oregon per year. About 10 or 15 years later, we recognized as a society that child sexual abuse was common. This was in the early 1970s, mid-1970s. So we moved from recognizing physical abuse to be able to recognize that child sexual abuse was a common phenomenon. It turns out that Freud was right after all. Freud had a series of about 23 or 24 patients, a third of whom were men, whom he diagnosed as hysterical, who reported to him that they had been molested by relatives or close family friends when they were children. He was ready to write a paper and present a paper at a psychoanalytic association on this phenomenon of child sexual abuse with consequent psychological difficulties. And again, society was not ready to accept this, and he was actually forbidden to present the paper and had to recant formally that he would have this wild idea that large numbers of children might have been molested by trusted friends. So Freud has been vindicated recently. Now in the 1980s and 1990s, we're facing new issues. The issue is defining emotional abuse, which many people feel may be even more harmful long-term than physical abuse or sexual abuse, and sometimes accompanies physical abuse or sexual abuse, or almost always does accompany those types of abuse. But defining emotional abuse and being able to prove that emotional abuse has occurred is very difficult. Some of the other issues in the 1980s and 1990s are recognizing that there are many more female offenders, especially in the area of child sexual abuse, than we ever suspected. And then the whole area of treatment of offenders. And then the new area of child abuse, which we've just moved into in the last few years, which is drug-affected infants and abuse related to drug use in the home. And that, I'm going to talk about that in a minute. So I think it's very encouraging that we've recognized as a society that children are being abused. It's also encouraging that as we recognize it, we're willing to do something about it, something that we need to do to avoid paying the price of child abuse and neglect. And what is the price that we pay eventually when children are abused in our society in large numbers? One of the prices is prostitution. A number of studies show that many prostitutes were sexually abused as children. If you take adolescent prostitutes, between 65 to 100% of them report child sexual abuse when they were younger. Of adult prostitutes, between 65 and 95% report that they were abused before the age of 10, a forced sexual contact before the age of 10. So one of the consequences of allowing child abuse to occur in our society is prostitution. Another consequence is criminality. Various studies again show that between 70 to 90% of criminals were abused emotionally, physically, or sexually when they were children. It's hard to get at that figure precisely. For example, my husband works with sexual offenders, and one of the things that they do is survey them about their childhood history. And one of his clients said that he had not been abused when he was a child, but later on there was a question about at what age was your first sexual contact? And the answer was 8. With whom? A relative. So that wasn't even defined as child sexual abuse, where we would define it as child sexual abuse. Another consequence is severe eating disorders. A nurse who works in a local inpatient treatment unit for severe anorexia and bulimia, people who have those disorders so severely that they need to be hospitalized, has told me that they believe that between 90 and 100% of their female clients were sexually abused as children, and that report is coming in from around the country. Other consequences are mental illness, sexual dysfunction, difficulty in maintaining relationships. If your ability to control your body and to develop healthy relationships as a child is taken away from you, then of course you're going to have difficulties later on. Some of the things that have been found in the area of maintaining relationships, if you've been abused, are an 8-fold higher rate of abuse by a mother of her own children if she herself was sexually abused or was the victim of incest. Women who were victims of incest or of sexual abuse have a 2 to 5 times higher rate of being raped later on. Interesting connection. We don't know exactly why. A victim becomes re-victimized. There's a 2 to 10-fold higher rate of alcoholism and drug abuse among people who were victimized as children. So the price that we pay for child abuse ultimately is quite high. As we recognize the price that we pay, we have to ask ourselves, how can we prevent child abuse? Because if we recognize and treat child abuse early on, we pay a much lower price than if we treat its consequences later on in terms of trying to do something about prostitution, drug abuse, alcoholism, criminality, eating disorders, difficulty in maintaining relationships, and so on. In Oregon, we've recognized that we need to do something to prevent child abuse in many ways. The Children's Trust Fund is an example of that. Only a few strategies have been proven in studies to prevent child abuse. We have many, many different programs to prevent child abuse, but only a few have actually been proven. One is the home health visitor. This is a person in many countries who goes out after any infant is born. It doesn't matter if they're lower class, middle class, or upper class. Any infant that's born, someone goes out to the home and visits regularly over a period of months or even a year to make sure that things are going okay at home and can intervene if they see some problems. So a home health visitor is one thing that's been shown to prevent child abuse. It doesn't have to be a physician. It's just someone trained in child development and child health care. And in fact, I was talking to someone who knows one of the new Supreme Court justices in the United States, and he said that it was Justice Kennedy, and he was visiting in New Zealand and speaking to his equivalent there, a Supreme Court justice in New Zealand, who felt that in the Plunkett nurse era, there was an era in New Zealand in which they had nurses who went out to the home for every infant that was born and visited with the family and worked with the family over a period of time. And this justice in New Zealand was saying that he felt that there was a lower rate of delinquency, juvenile delinquency, in those children who had been born in that era when there were home health visitors. And he felt that was a very important thing to enact if we wanted to prevent later child abuse and delinquency. The second thing that's been shown to work to prevent child abuse is a regular provider of health care. If families can come and consistently see someone who knows their family and can watch again for problems to develop and intervene early, then we can lower the rate of child abuse. The question, though, as we're developing strategies to try to prevent child abuse is, are we willing to pay the price? Again, if we don't pay the price early, to recognize and treat child abuse early, we're going to pay a much higher price down the line when the consequences of child abuse become evident. And it's not just a dollar price that we're talking about. Are we willing, for example, to let people come into our homes when our newborn infant comes home? We who think that we are at no risk of child abuse and neglect. It has to be a universal program. Child abuse occurs across all socioeconomic levels. Are we willing to have our child or our grandchild visited by a home health visitor for 6 months or a year? Are we willing to have some unwarranted investigations of allegations of child abuse? That's a price that we have to pay if we're going to guard our children. Just like we occasionally do an operation for suspected appendicitis and we discover that the appendix isn't inflamed, occasionally we're going to have to investigate alleged cases of child abuse that turn out to be not to be child abuse, and we're going to inconvenience a lot of people as that happens. The story I always tell is about my own family. When my child, who's now in college, was 2 years old, he had a series of accidents. We were going abroad. He had a smallpox shot, so he had a big scab on his shoulder, and he had a fever. He had been, as we were packing, somebody was babysitting him and gave him a drink at a drinking fountain. He came down hard and almost bit his tongue off. So he had this huge cut in his tongue. And then a day later, he had just learned that he could turn the light switch on and off by climbing up on the back of the couch and flicking the switch. And he was doing that, and he fell off the couch and then refused to walk, and it turned out he had broken his leg. So I had to go into my own emergency room and tell my own colleagues that my child had fallen off the couch and broken his leg. And that happens to be the most common story that abusing parents use to explain the injuries that their children have sustained, like a six-week-old who rolls off the couch and comes in with fractured skull and a fractured arm. The parents always say he rolled off the couch. So I had to go into my own emergency room with this story, and they said, yes, of course, right, he fell off the couch. We know what happened. So we have to be willing to be subjected to some scrutiny when things like that happen in our families if we're going to prevent child abuse. And this is a very controversial issue. Are we willing to control guns to prevent child abuse deaths, to prevent deaths, unwarranted deaths in children? Because homicide is now the leading cause of child deaths in many cities. So are we willing to pay the price? That's one of the questions. Now I'd like to talk about drug-affected infants. This is a new area of child abuse, and it's experiencing some of the birth pangs and difficulties that we experienced when physical abuse became known in the 1950s and 60s, and child sexual abuse became known in the 1970s. Let me give you a little background. 10% of pregnant women are using illegal drugs. This is across the country, and it applies to Portland too. Surveys have been done in the Portland area, and we found that 10 to 11% of pregnant women are using illegal drugs. This does not count alcohol. Only illegal drugs. In some hospitals across the country, it's 30 to 50% of newborn infants, particularly prematures, have drugs in their urine. This means in Oregon, 3,800 drug-affected infants born per year, which means that today, 10 drug-affected infants will be born in Oregon. This does not count the infants damaged by alcohol, which is a legal drug. About 1 in 200 infants, we believe, is born damaged by alcohol to some extent. Alcohol abuse during pregnancy is now the most common cause of mental retardation in the United States. So the incidence is high of infants born damaged by alcohol or by drugs. What is the damage? I'm going to use cocaine and methamphetamine as the example because those are the most common drugs that we see in Oregon now. But understand that almost no woman who's using drugs uses one drug. Most are polydrug users, and they use a little bit of alcohol in addition to the cocaine, or they use the cocaine, but if they can't get it, they smoke marijuana and so on. So it's hard to find a woman who only uses one substance. Cocaine and methamphetamine cause smooth muscles to contract. If that smooth muscle is in the uterus, it causes the uterus to contract. There's a much higher rate of abortion and premature birth in women using cocaine during pregnancy. Unfortunately, cocaine also seems to increase fertility substantially. So we're seeing many women who are bearing cocaine-damaged infants every year. We have some women in their 20s who have 4 cocaine-affected infants already. It also causes the smooth muscles in blood vessels to constrict. Now, if that blood vessel is in the placenta and that placenta is supplying all the nutrition to the fetus, then the nutrition is cut off to the fetus. So cocaine and methamphetamine babies and also heroin babies and opiate-affected babies are born smaller than normal. Their weight is low, their height is low, and more importantly, their head circumference is small compared to their small bodies. And head circumference represents brain growth. So we have severe concerns about brain damage in these children. If the blood vessels that supply the developing brain are cut off, you can get a stroke in a newborn. We have seen that. And in fact, there's one study in which they did computerized CAT scans or MRI scans of the heads of infants born to mothers using cocaine or methamphetamines, and they found that 27 to 33% of those infants had multiple areas where the brain had been damaged, presumably by small strokes, as the brain is developing in the uterus. If the blood vessels supplying the heart are cut off by cocaine or methamphetamine, then you can have babies born with heart attacks. That has happened. If the blood vessels that are supplying developing organs like fingers, toes, kidneys, parts of the bowel are cut off, those parts can be missing or severely damaged, and we have infants with missing fingers, toes, kidneys, and so on. Later, what are the consequences? We don't exactly know because we just started seeing large numbers of drug-affected babies in the Portland area in the 1986. So these kids are just beginning to hit preschool and school, but we know we're in for trouble. The studies that have been done around the country show significant damage. Drug-affected babies show problems with speech. They show problems with spatial coordination. That's like doing puzzles or orienting their body in space to do athletic activities. They have trouble with coordinating their body properly. And I think one of the most, they're hyperactive, they have difficulty paying attention, sitting still, attention deficit disorder. But I think one of the most disabling consequences is that they have trouble learning from consequences. And one foster mother who's taken care of a drug-affected baby who has now failed 2 adoptive placements at age 3 told me that the potential adoptive parents said that they could not take this child because she was evil or immoral. And the foster mother was very astute. And she said it's not that the baby's evil or immoral. The problem is the baby doesn't learn from consequences. So if she does something wrong, like hits her sibling, and you give her time out, she doesn't realize that that's related to what she did, and she'll come back and hit the sibling again. So you can imagine the problems we're going to have in school with children who have who are hyperactive, learning disabled, and have difficulty learning from consequences. We also have concerns about children being raised in methamphetamine houses who are being exposed to lead and liver toxins in the precursors that are used to manufacture methamphetamine. And we have concerns about AIDS. Children whose mothers use drugs have a higher incidence of sexually transmitted diseases, and there is a prediction that by 1996, half the pediatric beds in the country will be occupied by children with AIDS. Children who are born to drug-using families also have a higher risk of subsequent abuse and neglect. In one study, the risk was 40%. If you were raised in an addicted household, there's a 22% chance that you will be physically or sexually abused, and another 20% chance that you will be chronically neglected. This stands to reason. If a family's resources, in terms of time, money, energy, is going to acquiring the drug, using the drug, and then being spaced out on the drug, all the resources that go to the drug are resources that are not available to the child. And we talk to children at the CARES program who are essentially taking care of themselves. I talked to one 5-year-old who had been placed in protective custody, coming from a drug-affected family. She had 3.5-year-old twin sisters. And she was telling me that the food in the foster family was fantastic and the foster home was fantastic. So I said, well, what was the food like before you went into the foster home, in the home where you used to live, your regular home? She said, well, I did the cooking. She was 5. And I said, oh, well, what did you cook? And she said, well, I made peanut butter and jelly and peanut butter and honey and peanut butter and sugar. She said, my sisters wouldn't eat it all the time. I'm not a very good cook. So these are kids who are raising themselves from age 3.5 on. These kids are also being given drugs. We thought that the drug exposure ended when a child was born and was out of the uterus and the umbilical cord was cut. But that was a very naive belief, looking back on it. We have had many cases. This is an example. About 1.5 years or 2 years ago, we had a 3-year-old who came into our emergency room with a laceration that needed to be sewn up. He'd been cut on a piece of broken mirror. And the mother remarked that he had alcohol on his breath. Indeed, he did. His blood alcohol level was 0.08, which is legally intoxicated for an adult. And she thought he might have gotten into a beer in the refrigerator. We screened his urine, and he also had cocaine and marijuana in his urine. That is not a coincidence that a 3-year-old has alcohol, cocaine, and marijuana in his system. Children are being given drugs. In a house where stress is responded to by using drugs, it's logical that if your child is causing you stress or is in pain, you give him drugs. And we have talked to mothers who have been living in crack houses or been in crack houses, and they talk about children being gathered around a woman who is babysitting them and who is blowing cocaine or marijuana smoke into their noses to keep them quiet. The reasons are threefold. One is to keep them from going outside and being picked up by law enforcement or child protective services who may be looking for the children or the family. 2 is to keep them quiet so the crack house won't be busted. And 3 is to keep them quiet and sedated so they won't wander off into other rooms in the crack house where they might be sexually molested by a man in the crack house. So you can see how the lifestyle develops around the drug. In interviewing children at CARES, we now routinely ask them about drug use in the home. And we're very relieved when we ask a child, do you know what Coke is? And they say, yeah, it's that drink you drink out of a can. Because many children at age 3, 4, 5, 6, and 7 think that Coke is the white stuff that you put up your nose. What do we need? What do we need in this area, especially the area of drug-affected infants, which is our newest crisis in child abuse? We need education to prevent people from getting on drugs, and we need that education from kindergarten up. It's too late by junior high. And I think we need to tap into the knowledge that people who work in public relations and work in shaping people's preferences and choices, we need to tap into that knowledge and use aids like videotapes to reach people who don't read and reach kids at kindergarten, first grade, second grade, third grade level. Many kids know the fried egg commercial of this is your brain frying, and a lot of kids know that and tell me about that when we ask them what is drugs. We have been successful in turning around the idea of drunk driving being acceptable in this society. That's turning around. We're also turning around our idea about smoking in this society. And if we can do it with those 2 things, we may be able to do it with other drugs. Second thing we need is inpatient treatment for drug-addicted moms or anybody who's on drugs. Inpatient treatment is vital. We need, for pregnant moms or drug-affected moms, we need what I call beds and cribs. A bed for the mom and a crib for her children, so that she can be treated while her children are safe, and she can be learning parenting skills and be observed in her interactions with her child. We have very few inpatient treatment beds in Oregon or even in Portland currently. We also need treatment programs that demand clean urines. I have a very strong feeling that you can't say that you're treating someone for drug addiction if they're still using drugs, that not until their urine is clean are you truly treating them for the addiction. We also need protection for drug-affected infants. We need legal sanctions. We need to make, under our mandatory reporting statutes, the category of drug-affected infants in this state. It is included in a number of other states, but we haven't been able to include it in our statutes here in Oregon. We do include it in our hospital. We report all drug-affected infants, but that's not a statewide mandate. And we need to protect our infants in some way while their parents are getting treated, with the goal that those parents will get clean and then will be able to take custody of their children back and become the parents that they should be for those children. So it's a depressing field, but it's also an encouraging field. What keeps me going is that I feel that we're making progress. We have made progress in this society, in this civilization, in recognizing that people of different color, of different race, of different religion, different ethnic background have rights, and that those rights should be protected. And now we're extending that recognition to animals, animal rights, to trees. Witness our recent debate about the rights of loggers, foresters, owls, and trees. We recognize that trees have rights to a certain extent. And we're extending that recognition to children too, that children have rights that need to be protected. And when we move to protect the rights of children, we're protecting our own rights. And we're making, I think, a much brighter future for ourselves, for our children, and our grandchildren. Thank you.
Thank you, Dr. Bays. For those of you who are brave, the microphone is being placed in the center of the room. For those of you who are shy, on your tables are forms for written questions. The first question comes from our board host, Pete Baer.
Thank you, Bill. In deference to Bill's earlier comments about the fundraising campaign, I will defer until Monday and Tuesday when a number of volunteers will be on the phone and certainly will ask for your badly needed contributions. Dr. Bays, recently the publicity that surrounds the Ecclesia commune and the death of Dana Broussard has indicated that at least the 4 individuals who've been most involved in that death will be prosecuted. Unfortunately, or at least from my perception, a number of the adult members of the commune who consistently and repeatedly were involved in physical abuse of the other children do not seem to be being prosecuted. I guess my key question is, what are the deficiencies in the state statutes? What are the deficiencies in the judicial system? And what are the deficiencies in the state agencies and their ability to enforce that are precluding those people from being prosecuted? And secondly, can the state really be seriously considering giving those children back to their parents and putting them back in that environment?
Well, that's a loaded question. I don't think I've got enough time to answer it completely. You know, but it's an issue that isn't just the issue of the Ecclesia case. It's the issue in all child abuse cases. We're trying to balance rights. And in our country, the right to have children is a sacred, untouchable right. And when we suggest things like, gee, isn't it interesting that you have to have a license to drive a car? Not only that, you have to have a license to cut hair and to do nails. Now, if you're given a bad haircut by a hairdresser, that hair will grow back eventually, hopefully. But if you maltreat a child, the damage may be permanent. Now, I'm not suggesting, because this is an impossible thing to suggest, that we license people to have children. But we maybe need to look at training people about having children and how to take care of children. And I was delighted when we moved to Oregon to find that there are mandatory classes for kids in high school called marriage and family counseling, and they work with issues of raising children and being married and so on. And I think that's a step in the right direction, but it needs to start much, much earlier, because by that time people's ideas about child rearing have been solidified. I do think that we have a long way to go in our judicial system in terms of recognizing the rights of children in the judicial system. The judicial system is set up for adults. And if you've ever been in the courtroom when a small child is brought in, I'm afraid to go to the courtroom. It's terrifying for me to go to the courtroom. Imagine if you were 5 and you had to testify that the person who's sitting right there glaring at you harmed you in some way, especially if it's sexual abuse, which is very embarrassing to talk about. And we're working in a kind of clumsy way, I think, nationwide to begin to try to protect the rights of child victims. It's another step in our recognition of the fact that children are abused, and then once they're abused, the system tends to re-victimize them in trying to investigate the abuse, trying to do something to protect them from the abuse, and in the judicial process. So I think we have a long way to go, but we're making steps in that direction. In terms specifically of the Ecclesia case, I would say that those children were not only physically abused, but that there was a lot more that went on, that if anybody ever, the court proceedings are open, and if anybody ever wants to find out more about that case, I would invite them to come to some of the court proceedings. We as reporting agencies are bound by confidentiality laws, so we can't say a lot specific except in the courtroom when we're required to under oath. And that puts us at a disadvantage, because the family or the organization or the group that's accused of abusing children can say whatever they want, and we can't say anything back.
I'm Catherine Augustin, member of the City Club. I'm an attorney, and I do mostly family law and a lot of child custody law. And myself and a lot of other attorneys have found that in cases where divorces are in process or there's a post-decree modification of child custody pending, there's an extremely high incidence of false reporting of child sexual abuse. Have you, in your work at the CARES unit, kept any information or statistics on the high incidents of false reporting, and can you give us any suggestions or advice in how we deal with these incidents?
Sure. This is a concern around the country, not only in child custody cases, but in terms of false reports of any kind. There are diseases that can look like child abuse, both physical abuse and child sexual abuse, so we're trying to make sure that professionals are well trained in recognizing these other conditions that could be confused with child abuse. In the area of custody disputes, unfortunately, children are again the victim. When a divorce occurs, children suffer. And now they suffer doubly because people have learned that in throwing accusations around in ugly divorce cases, one of the accusations that brings instant results sometimes is the accusation of child sexual abuse. And that often visitation will be suspended, a long investigation will ensue, usually a very costly investigation, both financially and emotionally, for the family. We have seen some cases at the CARES program. It's too hard to work out in one visit, and usually people come to our program for one visit. If it's truly a custody dispute and the accusations have arisen in that context, it's usually better worked out over a longer period of time with multiple visits to experts who can evaluate both parents and the child with the parents. Nationwide, there have been several studies done on this issue of how often do false allegations of child sexual abuse arise in custody disputes, and the studies show that it's very rare that false accusations arise in custody disputes. Now, I think the cases that we know about are very problematic cases, and so they fill our reality. But don't have the statistics on the tip of my tongue, but as I recall, custody disputes arise in about 5% of divorces. And in that 5% of divorces, in about 1 or 2% of the cases, are there even accusations of child sexual abuse, and the majority of those turn out to be true. So it's a huge problem when you're dealing with it, but nationwide it's actually a much smaller problem. But we're acutely aware of it.
Ralph Crawshaw, City Club member. Thank you, Dr. Bays, for your fine presentation. I wonder if you could be a little more specific about the size of the job ahead in order to provide prevention and adequate care. Specifically, how many beds do we have available in Portland, Oregon for inpatient treatment of these mothers? How many do we need, and what do you estimate is the cost of the difference?
Okay, good question. The beds that I'm aware of, well, it partly depends on whether you have private insurance and are able to pay for inpatient treatment. If you have private insurance and you're able to pay for inpatient treatment, then access is not difficult. If you're on public assistance or haven't the $6,000 to $10,000 that it requires to be in inpatient treatment for a month, then it becomes much more problematic. And I don't know the exact number. I know that Ecumenical Ministries just opened a house that has 17 beds. And I think that about doubled the capacity in Multnomah County. I think there are several dozen beds available. And I know that the Ecumenical Ministries 17 beds have quite a long waiting list for moms to come in. In terms of cost, there was an excellent documentary on KGW TV called Children of Cocaine, and they compared the costs of treating a mother who's pregnant and a drug addict in jail, keeping her in jail, keeping her off the streets, and treating her, giving her prenatal care in jail, treating her in an inpatient treatment facility, bearing the cost of a premature or drug-affected baby. And when those three things were compared, it was something like $100,000 to $300,000 if you let the baby be born and then tried to take care of the baby later on in all of its difficulties. If you had the mother in jail for the duration of her pregnancy, it was something like $50,000. If you had her in inpatient treatment, it was $10,000 to $20,000. So it's by far the cheapest option, but not available yet to the women who really need it.
Bob Wise, City Club member. Dr. Bays, I'd like to ask a question. You mentioned a number of the things that should be done in terms of social responsibilities toward children and programs. My question is really what, in your view, are the main things that individuals can do? Of course, their parental roles are central, but beyond that, in terms of their citizen roles, what really needs to be done most for those that might want to get involved?
Sure. I think you have to pick the area that's closest to your heart. For example, I'm now very concerned about drug-affected babies, and one of the things that I'm going to do is buy the video documentary Children of Cocaine and donate it to our school system to use in educational programs for the school system. So, and I see that if we can intervene early and get people not to use drugs, that we have a hope of fighting this problem. Even if everyone stopped using drugs today, we still have this huge group of children who are already born damaged that we're going to have to deal with in the school system, then when they become adolescents, then when they become adults. And we can't keep working at the far end. We have to work at the close end in prevention work. There's the Children's Trust Fund. There are a number of organizations that are working in the front end. But pick the thing that's close to your heart that affects you the most, I think.
Joella Whirling, club member. You've given us a number of horrifying statistics. I'd like to add another one and ask you a question about it. I heard this at a state education meeting that 70% of the inmates in Oregon penitentiaries were born to teenage parents. And I wonder if you could give us some kind of profile of the parents of these children that you work with at the hospital. Secondly, we have a tragedy in the community, the kidnapping and murder of that little boy, Lee Isley. And this perhaps also gives the community an opportunity. Have you any thoughts along the line what those might be? Thank you.
Yes, it does often take a tragedy to bring this to our attention. That's unfortunate, but anything that will mobilize us, I think, is important too. In terms of teenage mothers, it's interesting. We know that teenage mothers represent a high-risk group, but we have some good programs working with teenage mothers, and we have found among our drug-addicted mothers that the teenagers actually did the best. That they hadn't been using drugs that long. They were frightened by the damage they might have done to their infant, and the teenage mothers who were drug addicted were usually able to turn their lives around and get off of the drugs much better than the mothers who were 25, 35, or 38, who had been using, some of them since they were 12 or 13. So I have a lot of hope in terms of working with teenage mothers or first-time parents, that if we can work with them intensively, we can prevent child abuse.
My name is Jay Howe. I'm a City Club member. Doctor, do you think that all newborn babies should be tested to determine if they're drug affected? And if such testing is not done, we run the risk that there will be drug-affected babies who go home and are subject to continued abuse.
Yes, you've asked a question dear to my heart. Definitely. We now test by mandatory state law children for a variety of diseases, phenylketonuria, which occurs in 1 in 30,000 children, low thyroid, and so on. These are all conditions which can cause mental retardation if not caught early. So here we're testing for something that affects 1 in 30,000 infants, but we're not testing for the 1 in 10 infants who are affected by drugs or alcohol. And if it were my preference, if I had to make the decision for the state, I would say yes, we should do drug screening on all newborn infants. We now are doing drug testing on infants that we know to be at risk. For instance, prematures, any of the medical conditions that I talked about, mothers who aren't getting enough prenatal care. It means that there's a bias towards the poor mother who doesn't get prenatal care, whose life is disorganized. But we know we're missing drug-affected or drug-using mothers who are middle class, who have good nutrition, who get prenatal care, and who can hide from their obstetrician and pediatrician the fact that they are using drugs. And then are finding when the child enters school that for some reason it's not doing well in school. And I think we need to pick up those children when they're born so that we can plan realistically, medically for their needs, anticipate their problems before they get into school and get into trouble.
Tom Stanwood, member of the City Club and Law and Public Safety Standing Committee. You've mentioned a lot of the problems and a lot of the needs and potential solutions today. But given our limited resources and priorities in the state, where do we start? I know that sounds simplistic, but somehow, somewhere, we've got to find the start point and go from there. I'd be interested to know what is your highest priority.
Sure. I don't think there's just one start point. I think if I had to choose two things in terms of drug-affected infants, I would start with drug education beginning in kindergarten, and it needs to be well designed. We need to use the public relations people, advertising people well, and their skills well. And then second, on the other end, we need inpatient treatment beds for women who are addicted, and their children need to be included in that program. Dr. Ira Chasnoff, who works with drug-affected infants at Northwestern University, just got a federal grant to take an old hospital that had been closed and have it remodeled, and they're going to open 60 inpatient treatment beds for drug-affected women and their children who will be treated in one facility. And I think that's the direction we need to move in terms of prevention of all forms of child abuse. I suppose if I had my preference, I would start out with home health visitors, people who are working with the family intensively in the first year of the infant's life.
B.J. Seymour, City Club member. You mentioned just in passing that emotional abuse was one of the problems we were beginning to recognize. How do you document cases of emotional abuse?
It's very difficult to document. Usually we have to have information from many people who have overheard what has been said to the child, and even then it's often not enough to convince, say, a court that emotional abuse is going on. So the kinds of things that happen is a child who's repetitively told, "I wish you were never born, you're so stupid, I wish we never had you, you can't do anything right." And then milder forms, and we had a child who came into our clinic a couple of years ago, and the mother said, "Be quiet or I'll tell the doctor to stick a needle in your tongue." Well, it's like, oh great, now I'm going to have a wonderful time trying to examine this child. I mean, to me, that's emotional abuse, but that one little incident is, if you document that, it's not going to get you anywhere. We're going to learn about emotional abuse. There'll be changes in the next 5 years.
Dan Goldie, City Club. I wonder if you have any statistics that relate to plant closures, economic catastrophe in a community, and its relationship to child abuse. And if there is a strong corollary between the two, when we see plants closing down and a community shutting up, can we, in effect, anticipate that kind of a problem and take action to prevent it?
Yes, that's a very good question, and those studies have been done. Whenever there's an economic downturn, the rate of child abuse goes up, and that's a statewide statistic, but it's also local statistics. A friend of mine who's a physician in Washington said that in a town when a plywood mill closed, they had within 2 weeks, 3 incidents of child abuse in that one town because of the added stress put on the family by the loss of the father's job. So yes, I think that's a wonderful thing to look ahead to situations where a family that may be coping fairly well, then because of stress, and sometimes stress combined with use of alcohol or drugs, which may decrease people's natural inhibitions to harming their children. We need to intervene in situations like that where we see a high-stress situation coming up, yes. Better to intervene early than too late.
Kitty Wheeler, City Club member. Given the fact that we live in a democracy, what can we ever do and should we attempt to do parental dissolution of rights and that one cannot become pregnant and a tubal ligation type thing for those who are abusing?
I've talked to some of, this is a question that comes up every time that I talk, especially on the drug-affected infants question, because we have mothers, as I said, who are having their 4th drug-affected infant. And some of them have signed consent forms for tubal ligation, but there's a 1-month waiting period during which you can change your mind. Well, 1 month is forever if you're using drugs, and it's gone from your mind. And we've even had a couple of mothers who had signed the consent form for tubal ligation who were on the stretcher ready to go down to the operating room, and there was some delay in the operating room for 20 minutes, and they got up and left the hospital. So we need to work with people who understand the mind of a drug-abusing person and to understand how to get them to use birth control or to consider sterilization. It cannot be forced in this society. I've talked to many of my legal friends, and they say it's an untouchable, the right to reproduction in our society as it now stands is an untouchable right.
My name is Dave Olson, member of the club. What could we do in the field of foster care to reduce the level of child abuse?
We do need more foster homes. We had an appeal recently by the governor's wife because of the increasing number of drug-affected infants who are coming into foster care, and we're beginning to see families who are abandoning their drug-affected infants in the hospital. This is a phenomenon they've seen in New York City for a while, and they have wards of several hundred abandoned infants who are just sitting in hospitals. It's the old kind of foundling home situation. Not good for these children at all. They should be in loving, caring homes. And I'm worried that that's going to come in Oregon, and we need to have more foster homes, and we need foster homes that are trained in dealing with children. For instance, sexually abused children often act out sexually in the foster home and will approach the foster father, climb on his lap, unzip his zipper, and so on. I mean, you need to be trained how to handle that. Many anecdotal stories about that, which I won't go into now. And also, the drug-affected infants are very hard sometimes to raise because they don't sleep on a regular schedule. They'll sleep for 20 minutes, cry for 20 minutes. They have a shrill, high-pitched cry. They tolerate change very poorly. They're sometimes very, very hard to deal with. Our nurses at our hospital say they're glad to go home after an 8-hour shift with a badly drug-affected baby. But a mom can't go home after 8 hours, and you put that baby with a drug-using mom, you can imagine that's dynamite. So we need good homes that are trained specifically to take care of these infants. Definitely we need more foster homes. I have to say that the foster mothers are the unsung, and fathers are the unsung heroes in our business, that they're willing to take children anytime, day or night. There's a knock on the door, and 3 children whose names you might not even get straight, who are frightened because they were just taken out of a methamphetamine lab. They have been stripped because of all the toxic chemicals in the lab. They have been hosed down. They have been put into into paper suits and brought to your house reeking of the chemicals from the methamphetamine lab at 3 in the morning. And then all their possessions have to be destroyed because of the toxic chemicals. So they come with nothing and will have nothing. You can imagine trying to cope with that as a foster family. Some of the foster families are fantastic.
Bob Wheel, member, you deal with the dire effects of drug use. In your opinion, what would be the results of legalization of drugs? Would it increase or decrease the problem?
Boy, that's a problem that an issue that we debate all the time at the hospital, and we have a law enforcement officer who's assigned to the CARES program who feels that legalization would be a step forward. I feel that it would be a step backwards, because right now one of the only holds that we have over a mother who has born a drug-affected infant is that she has used an illegal substance, she has administered an illegal substance to her child and has committed child abuse. And if that hold were gone, we would have no consequences. This is an issue that's come up in child abuse throughout the decades. At first, when physical abuse was discovered in our society, people were reluctant to prosecute families for physically abusing their children. They felt it should be handled as a social issue, it should be handled by social services agencies, therapy for the family, and so on. They discovered it didn't work. People don't want to change unless they're forced to change. So they began to do some prosecution in selected cases of child physical abuse. Then the same issue came up with child sexual abuse. People said, no, it shouldn't be prosecuted. We shall handle it with social services agencies and with therapy. Well, it turned out that sexual offenders don't want therapy and usually won't stay in therapy unless it's mandated. And now the same thing is happening with drug-affected families. They don't want to go into treatment, or they won't stay in treatment, because addiction is one of the most powerful forces I have ever seen in my life. It is so powerful. And mothers will say to us, and I know they mean it, for the sake of my newborn baby, I will stop using, I will never use again. And they mean it at the time, but 2 days later they're using again because addiction is so powerful. And we need some force that has a little bit of power against that huge force of addiction. And right now, all we have is legal. So for that reason, I'm not in favor of legalizing.
Ron
Last
Feitner,
question.
City Club member. Dr. Bays, how well do you think the doctors are fulfilling their role in educating pregnant mothers or those considering pregnancy as to the adverse effects of drug and alcohol?
Yes. We are not fulfilling our role, is the answer. Physicians, like everyone else, want to deny that child abuse happens and that 10% of pregnant mothers are using drugs. Especially they want to deny it that the nice mom who's sitting in their office right now is using drugs. And we just have to be comfortable talking. It took me a while to be comfortable talking to child about sexual abuse. And then it took me a while to be comfortable talking to a mother about, have you smoked during this pregnancy? Have you used vitamins? Have you had any alcohol to drink? How many fifths a day do you drink? You know, we're taught, that's how we're trained to ask. You start high. And if people go, fifths a day, are you kidding? Then you can move down, you know? But some people say, I drink a fifth a day. So we have to be trained to ask about this as a natural part of giving health care to people. Thank you.
I want to thank Dr. Bays again for an excellent presentation, and I'd like to take the opportunity, controlling the microphone and being the chair, to underline one thing she said. I strongly believe that this is one of those problems that's not going to get any better unless each of us takes the time to get involved. And I just urge each of you to take a little time and think about some way to help the children. We're adjourned.